July 26, 2024. This is the Room Now podcast, and I'm Dr. Jack Cush, executive editor with RoomNow.com. This week, we're going to talk about location, and the importance of geography. We're going to talk about lupus, some things that we may not think about as being important in lupus. And then I think we'll end up with some interesting data about chest CTs and coronary calcium scores. So I want to begin with this tweet I put out this week. It's a TriNetX retrospective. It's a TriNetX, I think, is a large database of EHR information. And as you'll see more and more of these TriNetX studies where they do propensity matching, comparing this to that. There are a lot of problems with the propensity matching and problems with some of the methodology. Some of these studies are really good, some of them not so good. And I think you need the epidemiologists that in your life. You know, we've got a few, don't we? Maybe we shouldn't. But to explain to you why this may or may not be valid data. Well, I found this report about the protective effects of metformin in lupus. So there's a retrospective study that looked at 9,200 patients on with lupus on metformin, not why, and compared that to almost 79,000 patients not on metformin. And they found that after propensity matching, that if you were a lupus patient and not on metformin, you had a significantly higher risk of lupus nephritis, CKD, and MACE, major adverse cardiovascular events, with anywhere from a 20 to 70% increase. And we've talked about the importance of metformin as co-therapy, and that often a lot of the benefits of metformin may not be related to control of diabetes or control of hyperglycemia. So I think this could be real. That's why I posted it. But I want to put in the proviso that if you're really into this kind of stuff, you're really going to need to pull the paper and really go over the fine details to find out if this really is important or not. Another study, a smaller study of the effects of krill oil therapy in lupus. This is a 24-week study where patients with lupus 78 patients with lupus were given 4 grams a day of krill oil or a placebo. And they followed them for 24 weeks, and then patients were given the opportunity to switch over from placebo to krill oil and follow for 48 weeks. Anyway, they found that this lupus cohort had a few things that are relevant. Number one, the average, we measure sort of your use of omega-3 fish oils by something called the omega-3 index. It's like DHA and EPA and a few other things. And the number is, in the general population, is low. The optimal number is above 8% for what's called a O3I, omega-3 index. Turns out the average population in the United States, not lupus, just average people like you and me, well, we're above average, but still our omega-3 index is usually around 4. And turns out that in this cohort of 78 lupus patients, their baseline O3I was 4.3%. After taking placebo, no change in their O3I. But after taking the krill oil, after 4 weeks, it went up to 7.2. And then after being on it for 24 weeks, it went up to 8.05. And 8 is sort of the right number. 8 is the number that reduces risk of cardiovascular events in a general population or high-risk populations. But this was a short 24-week study, just a few people. There were dropouts in the study. It was an imperfect study. But it did show that it did work as far as increasing the omega-3 index. And what was the benefit of that? None. For all the patients that were treated with krill oil, there was no real benefit. But they did a subset analysis. 9 patients had a SLEDAI-2K score, meaning disease activity greater than 9. And those patients actually did show a significant improvement in their SLEDAI-2K scores when they lowered their omega-3 3 index. So is that just, normalizing high levels and, migration to the mean, or is that really an association there? I think we should see some more studies on this in lupus. A study from Philadelphia looked at 154 patients with discoid lupus erythematosus. This was reported in JAMA-Dermatology. And in this study, they looked at the outcomes of DLE activity using the CLASI score, and they correlated that with a number of different things, including geospatially disadvantaged individuals as measured by something called, it's a geographic, where you live within Philadelphia, and it's called the Area Deprivation Index, or the ADI. So if you had an ADI of greater than 5, they said that you were geospatially disadvantaged. And that, there's a lot of things that go into that, but that would include education and financial matters, et cetera. And so it has to do with geographic density of where you live. But those who had an ADI, an Area Deprivation Index, greater than 5, again, geospatially disadvantaged, hadn't heard that until this week, those folks actually had a 4-fold higher risk of moderate to severe disease activity related to their DLE. Well, this is not the only report we had on location. I think it was the journal Pain that showed geographic differences throughout the United States and with regard to the risk of having arthritis-related pain or arthritis-related outcomes. And they did show that, and they tried to show this on a state level, but also on the county level. They did show that a higher level of pain and severe pain and arthritis outcomes was seen in the Deep South and Appalachia. Severe arthritis pain was more prevalent in the Southwest, Pacific Northwest, Georgia, Florida, and Maine. Really? So, again, another report where geography and where you live may impact the outcome, especially as far as a rheumatologist is concerned. An NHANES study this week from a few years ago, like 20 years ago, showed that in the NHANES population study, that 28% of the population reported erectile dysfunction. I have to assume that's the men. And 19% reported arthritis. But if you had arthritis, you had a 4-fold higher risk of erectile dysfunction. And that was mainly seen in osteoarthritis patients, where it was 11% risk, and rheumatoid arthritis, where there was a 3% increased risk. And those were significant. The question is, we don't talk about erectile dysfunction in my arthritis clinic, and we probably should. If you think about these numbers, of all your OA patients, how many of them are taking drugs for erectile dysfunction? This would say about 11%. I think that's about right. How many with RA are on drugs for erectile dysfunction? This would say 3%. And I think that's about right. In fact, it might be a little bit low if I look at my RA and OA patients. The point of this is awareness. There were reports in the past about erectile dysfunction being a prevalent issue amongst gout patients. There can be a lot of reasons for erectile dysfunction, including disability and inflammation and whatever, body image issues, age, etc. But again, it wouldn't hurt to talk about this, and wouldn't hurt to have a conversation about sex and intercourse and things that are important to patients, because then if you can't deal with it, then there's people who can, and your patients would appreciate that. A study of almost 5,500 patients with adult Still's disease looked at hospitalizations. In this particular cohort of 5,495 Still's patients who were hospitalized, they looked at a few things, but one thing they found was that those patients who developed MAS or HLH had a higher mortality rate than those who did not. So the incidence of HLH was 6.2% amongst these Still's hospitalizations. By the way, Still's disease doesn't kill anybody. You shouldn't die from Still's disease. But you may die from complications of steroid therapy or other therapy, and you may die from MAS or HLH. So this number of 6.2%, which I think is about right, is important. And what they found was mortality rates were 9% in Still's patients who had HLH versus only 1.5% in those who did not. So independent predictors of death in Still's patients who were hospitalized with Still's was, number one, DIC, a 6-fold higher risk, liver failure, 7-fold higher risk, infection, 3.7-fold higher risk, respiratory failure, 6.9, and thrombotic microangiopathy, a 14-fold higher risk. Now, Still's is rare. Hospitalizations with Still's is rare. And death from Still's is even more rare. But these findings do approximate that reported by Bella Mehta when she looked at this in, I think it was an NIHS survey of hospitalizations, and found that those were the predictors of bad outcomes in hospitalized Still's patients. I can tell you, I know Still's very well. DIC does occur, albeit rare. Liver failure is really bad. Infection is not uncommon. Respiratory failure, we're talking about that. Thrombotic microangiopathy, always a bit, for me, a head scratcher, but it has shown up, and it is in their literature. A study from the UK looked at how good are we who take care of IMID patients, immune-mediated inflammatory diseases. And this UK study that looked at 14,000 RA, 13,000 IBD, 3,800 SPA, 700 lupus patients. Overall, these 32,000 patients, only 57% of them were vaccinated against pneumococcus in one form or another. This number was lower if the patient was under 45, 32%. Was lower in IBD patients, 42%. And what they did show in this UK study was that vaccinating against pneumococcus had no association with flare of those diseases, RA, IBD, SPA, and SLE. So there's no good reason why your patients shouldn't be vaccinated. I did report on this association between myelodysplasia and rheumatic disease in weeks past. There's another report that just showed up this past week about a very large cohort of patients with myeloid neoplasms, including 861 with myelodysplasia, 640 with AML, and a whole bunch of others. And they found that amongst these patients with myeloid neoplasm-like disorders, rheumatic disease was present in almost 8%. The literature would suggest a risk of about 8 to 30% in patients with myeloid neoplasms and myelodysplasia, etc. The number was less in those with AML, 4.5% versus 9.5%. The most common autoimmune diseases that were reported here were RA and 42%, other connective tissue diseases 18%, and PMR and 14%. Vasculitis and AXPA was less. So the point being that it's not uncommon to have this association between rheumatic disease or myeloid cancerous disorders. And the question is, which comes first? In this study, I think it was that the myeloid neoplasm or myelodysplasia was the first event, and then autoimmune was often the second. But they can be the reverse as well. So curious. I found this study really interesting. A German laboratory study of 72,000 laboratory tests, and they're looking for how often they found abnormal tests for myositis autoantibodies. And basically, they found it in 209 patients, 238 tests. And the question is, for those, amongst as many thousands and thousands of laboratory tests, the ones who had a positive test, what was the etiology? And this was a head scratcher for me. You would think that they all had myositis of one form or another. Turns out only 18% or 37 patients had idiopathic inflammatory myopathy. More importantly, other inflammatory rheumatic diseases, autoimmune and other rheumatic diseases, not myositis, accounted for 43% of those positive results. And in 40%, actually 39%, they had no rheumatic diagnosis. how good are these myositis autoantibodies? I thought they had, when I've looked at statistics on them before, I didn't look it up for this report, but I thought they had reasonable sensitivity and specificity. This would say sensitivity, yes, but specificity, probably not. So just because it's positive, whether it's an anti-Jo1 or a NXP, doesn't mean that they are automatically going to have a myositis subset of some sort. I want to remind you that we did post up there a JAMA patient education handout on PMR. It's a fairly good handout. It's a one-pager. And I think that you should download that and hand it out to your patients. A few more reports, too, actually. One, a study looked at a number of, this is actually a study from Rush, I want to say. Doing that right? I think these are Rush patients, where they're screening patients in their clinic by either doing the MD hack or the Rapid 3. And they found that 36% of RA patients and 40% of OA patients screened positive for either anxiety, depression, or fibromyalgia using the MD hack or the Rapid. All three were found in up to 8% of patients. Rapid 3 was also elevated and abnormal in those who screened positive. And again, these are basically questionnaires. There are other things. I think we talked about PHQ-9 as a specific depression scale that you can do as an outpatient. But we've talked before about these being confounders in patient care, in those who don't respond, and in poor outcomes. It is important. So this is a big pitch for doing either the Rapid 3 or the MD hack, which has that information on the survey forms. By the way, it's also on the Room Now clinic follow-up visit form as well. We had a speaker at last year's Room Now Live. By the way, this year's Room Now Live is going to be February 8th and 9th, 2025. We're sending out the invitations right now to our faculty. I think you're going to love this program. We really love it. Last year, we had a great speaker from the Brigham, Brittany Weber, who runs the Arthritis Cardiology Clinic at the Brigham. And she had a recent presentation at the Society of Cardiovascular Computed Tomography. They had their recent 2024 meeting. And she presented data on 2,800 lupus RA PSO patients who did not have any evidence or prior history of atherosclerotic cardiovascular disease. And these patients that were studied all had computer tomography of the chest, and they found that only half of them had a normal or a zero coronary and these were, by the way, all identified by artificial intelligence. 47% had a zero score on their CAC. But having an elevated coronary artery calcium score was associated with a significantly higher risk of future mortality and or MACE events. So scores of 1 to 100 was seen in 30% of patients, 100 to 300 in 10%, and greater than 300 in 13%. They found overall that the coronary artery calcium scores was greatest in psoriasis and psoriatic arthritis patients. So each of these elevations, so as the higher you go up on the score, there's a higher increased risk of all-cause mortality, about a 40% increased risk, and about a 50% increased risk in MACE. So, and if you were really high at 300 or more, it was a 2.5-fold higher rate of mortality in MACE. So cardiologists like these scores. It's sort of like a staging procedure. Who should get more intensive evaluations with stress tests, nuclear or otherwise, or actual angiography. They're not totally predictive, but it may be helpful. And I think I would encourage my patients with chronic inflammatory disease, chronic and autoimmune disease, who we know to have a higher risk of cardiac outcomes. Why not do that if it's offered? You're now finding another good reason to refer to cardiology to get a more complete cardiac workup. Anyway, you can find these citations and more on the website. I hope you enjoyed this this week's podcast. We'll talk to you next week. And again, look forward to Room Now Live 2025, February 8th and 9th. Be there.